thank you very much for asking me to speak to you this afternoon. I was actually looking at, it was 2014, I think, when I last came to speak in Cambridge on this topic. So hopefully I'm going to try and give you a little bit of an update where I can. So I've added just my disclosures just to be politically correct. So what I'm going to try and cover in the next 20 minutes or so is I'm going to talk a little bit about the prognosis of encephalopathy. And this is a really big thing for me and something that I think is very underestimated, and when we should be referring people for liver transplantation. It's very, very important. I'm going to talk about how to diagnose HE, particularly early. I'm going to cover a little bit about the pathogenesis and precipitating factors. I'm going to talk about management principles quite broadly, underpinning particularly the management of acute encephalopathy. But I'm also going to try and talk to you a little bit about specific therapies for encephalopathy and where the role for prevention of recurrence comes in. And lastly, I'm going to talk just a little bit about the gut microbiome, which really is the biggest growing area in the field at the moment in encephalopathy, and probably where the newest sort of publications and data have come out since I last spoke to you all. So I've put this first slide up from Peter Jepson. So this is a Danish study of almost 500 cirrhotic patients. And really what I want to use this to illustrate to you is really that having encephalopathy, so when you develop decompensated cirrhosis and you develop encephalopathy, it really is the worst of all of the decompensating events that you can develop. And I think people often underappreciate that. So if you take a sort of average cirrhotic who presents to the clinic with no initial complications, their mortality over about 5 years is going to be about 17%. But when you have a patient who goes on to develop overt hepatic encephalopathy, you're looking at a mortality of about 80% at 5 years. So this is not a benign condition. And this is a very old study now. This is a study that was undertaken on just over 100 patients by Bustamante. And what they wanted to do is wanted to look at transplant-free survival in patients with hepatic encephalopathy. And I think hopefully what you can see here is, again, and much in line with recent data, is that the survival at 1 year is about 42%, but at 3 years, just 23% of your patients who have developed overt hepatic encephalopathy will still be alive. So really, when you see people in clinic with overt symptoms who've just been in with encephalopathy, you need to be asking the question, should I be referring this patient for transplantation? Because it may well be in 6 months' time when you next see them that they won't be around, or they'll have had a catalogue of admissions leading up to that time. So that's my first really, really important take-home message. But I also wanted to talk more broadly about, it's not just about overt hepatic encephalopathy. So we use this term now called covert encephalopathy, which sort of Bajaj has coined. And really covert encephalopathy is those groups of people who have very minimal symptoms or very, very low grade encephalopathy, which when most of the time it's more of a neuropsychiatric impairment than anything else. But it used to be that people would think that this isn't really a problem. This doesn't really have a poor prognosis, but what I want to show to you is that actually it does. So in this data that was published in 2014, if you look at the red Kaplan-Meier curve there, you can see that patients who have covert, so very, very low grade minimal encephalopathy, they have a far more increased risk of hospitalization compared to patients who don't. And even more importantly, you've got patients who have got minimal covert encephalopathy who also have an increased risk. Sorry, this is my slide going there. You've also got a substantial proportion of patients who independently have a worse survival compared to patients who don't. So this is really, really an important subject and not really something to kind of be neglected in the clinic. So how do we go about diagnosing encephalopathy? Well, it's not straightforward, but early detection is really, really important. And, you know, people will say, well, what's the best thing? Is this a clinical diagnosis? Do I do neurocognitive testing? Do I test ammonia? Do I do EEG? And yes, you can do all of these things. And I still believe that encephalopathy is a clinical diagnosis. But what I want to try to persuade you all to do is to do this test, which is so easy that can be done on the ward. It can be done in the clinic and is a great way of giving you a ballpark figure as to whether your patient might have encephalopathy. And that's the animal naming test. And you may have seen this sort of being spread wider and wider over the last few years. And basically what you ask your patient to do in 1 minute is name as many animals as they can. And in somebody who's fairly cognitively intact, without really any obvious encephalopathy, they should be able to name at least 15 animals. And actually, if you do it on each other, you'll probably find it would be more like 30. But what you will find in somebody who's got encephalopathy is actually they'll struggle to even give you 5 animals. And even when they do give you those 5, they will give you things like dinosaurs and mythical animals and really strange things, not necessarily conventional animals. So please have a go at doing this. It really, really is very helpful. And actually this has been validated. So this has been validated against using an EEG for diagnosis and the FES test, which is a neurocognitive battery. And you can see that it performs really, really well against both of those. And therefore is something that I think we should all try to be doing just to try to give us a better idea of who might be at risk here. So moving on now to pathogenesis and precipitating factors. Probably not a lot has changed here really over the, since I last spoke to you. But there's been a lot of contention about the role of ammonia and I wanted to briefly talk to you about that. So, you know, we know that in patients with liver disease and liver failure, that as you get worsening liver disease, you get worsening liver failure, particularly acute liver failure, your ammonia level will rise in quite a kind of linear fashion. But we also know that there are patients out there who present with really quite advanced encephalopathy who often don't have elevated ammonia levels at all. And there's this lovely study by Ong here that shows that you'll still see people with grade 3 and grade 4 encephalopathy with really quite low ammonia levels. And so therefore there is more to the presentation and what's driving it than ammonia. One thing we think probably is important actually is that people tend to measure ammonia levels after people have presented to hospital or to a clinical setting. But often what's happening by that stage is that people's ammonia is actually dropping. And the reason is that your protective mechanisms, which I'm going to talk about just in a moment, kick in. So what happens is your ammonia level probably rises to be highest in the 12 to 24 hours before a patient presents. And by the time we see them, it may well actually be coming down. And the reason why that's the case is that we have very, very intricate and coordinated trafficking of ammonia in our bodies. And in healthy individuals, of course, the liver removes ammonia by detoxification it into urea, and it's a very, very efficient process. But in patients with cirrhosis, clearly you've got that a metabolic capacity is reduced in order to do that, and you've also got a large amount of shunting going on as they develop portal hypertension. And therefore you have organs that need to take over that ammonia detoxification process. And the muscle is perhaps the most important of all of those organs. And your muscle is a huge sump of ammonia. It can actively take up ammonia, particularly overnight when you're asleep, and combine it with the amino acid glutamate to make glutamine, which helps build muscle mass. And this is a very, very important process. But also the kidneys are very, very important. And you know, they become a buffer, a very clever buffer that can excrete ammonia quite efficiently when ammonia levels rise in the bloodstream. But of course, that is reliant on having good kidney function. And really, it's only the brain that takes over as a sort of detoxification process once these two mechanisms are kind of overloaded or not working so well. And when blood ammonia levels do rise, what happens in the brain, and this is why we develop this sort of neurocognitive problems, is that ammonia is actively taken up by these star-shaped cells, these astrocytes, and ammonia combines with glutamate, which is your most prevalent neuroexcitatory transmitter, to make glutamine, which sits in cells. Now, glutamine is normally a good amino acid, but the trouble is it has an osmotic effect, and as it sits in cells, it encourages cells to draw in water and to swell. So what happens in patients, both with low-grade encephalopathy in cirrhosis, but also in people with acute liver failure, is that these astrocytes can swell and your brain can swell very quickly. And of course, in acute liver failure, this process can happen very, very acutely within literally an hour or so. Now, I've already mentioned that muscle is very, very important, and I think it is also it is very much underestimated. And what we've begun to learn is that not only do we know that patients with cirrhosis have reduced muscle mass for a variety of reasons, but also patients with overt hepatic encephalopathy are more likely to have less muscle mass than people without encephalopathy. So in this very simple study where they looked at mid-arm muscle circumference in 200 male cirrhotics, you can see that all of those patients that had overt encephalopathy, nearly all of them had less than the 25th percentile mid-arm circumference. So these people don't have muscle. And of course, muscle is a very, very protective mechanism to deal with excess ammonia in cirrhosis. So I've talked about how important the brain is and the muscle is, but also we're learning that the gut is very, very important in this process. And particularly there is movement of bacteria from the gut to the liver in both health and cirrhosis, which generates inflammation and kind of an inflammatory milieu, which is a major driver of a lot of the pathology in cirrhosis, but particularly in encephalopathy. So if you focus in the panel on the left-hand side, which is a normal healthy individual, you can see that normally we have a pretty robust gut barrier. You've got lots of bugs sitting in your gut, but they don't penetrate that barrier and they don't translocate into the portal vein or the liver. And when they do, they're very adeptly dealt with and there's no real sequelae. But in patients with cirrhosis, you get this leaky gut barrier and also an overgrowth of particularly bad bugs, which I'm going to talk more about later. So you get translocation of bacteria, particularly a lot of gram-negative species, into the portal vein and into the liver. And the problem is that your liver is full of Kupffer cells with TLR4 receptors that pick up endotoxin in these sort of breakdown products from these bacteria and initiate a very, very acute inflammatory response. So not only do you get a local hepatitis and inflammatory, but also you get a profuse production of a number of pro-inflammatory cytokines, which of course go straight into the bloodstream, cause a lot of other pro-inflammatory cells to degranulate, and you get this pro-inflammatory response and this endotoxemia. And we know now that this is a major driver of the development of encephalopathy. And when we think about precipitating factors, I'm sure I don't need to tell you this, but you know, if you had to outline what are the major things that precipitate our patients coming in to hospital, one might be an ammonia load. So we're thinking about something like a varicose bleed or a TIPS or becoming constipated. But the other overwhelming factor is infection. Even a very, very low grade infection will be enough to tip your patient over the balance and result in them pitching up to casualty. But also anything that impairs renal ammonia excretion will also play a major role here. But also hyponatremia is very, very important in this population and probably contributes more than we think to the pathogenesis. And again, this is because you've already got low-grade brain edema from ammonia. And of course, having hyponatremia just sort of basically makes that worse, exacerbates that process. And you can see from this Italian study that had over 1,000 patients that when they looked at cirrhotics in the clinic and looked at their serum sodium levels, when you looked at people who had a serum sodium level of less than 130, within the following 4 weeks, about 40% of these patients went on to develop encephalopathy, and quite a few, 25%, with those serum sodiums sort of in more of a moderate range. So be careful about watching your patient's sodium levels as well, particularly those prone to encephalopathy. So what about treatment principles now? So this is a little algorithm that I've drawn up. It's broadly based on the 2014 EASL and ASLD guideline, but it's kind of my own very basic interpretation. And I think the bottom line here for anybody, the bottom line message here is that you have to look at the severity of your patient when they come to A&E. And it's this group here, these patients with advanced encephalopathy who are comatose, who are drowsy, who are at risk of protecting their airway, that really are the most important. And these patients should be going to an environment where they can have their airway protected. So an HDU, an ITU, or certainly a medical ward where they're under very, very close observation. And the thing that with managing this group of people is it's about supportive care. It's about protecting their airway. It's about giving them fluids, and I'm going to explain in a moment why fluids are so important, and about covering for infection empirically, just for 72 hours if need be, until you know what's going on. And potentially, if you've got somebody who's very moribund and very high, potentially having a very high ammonia level, potentially putting them on a hemofilter, and that's frequently done in the intensive care environments. Don't worry about trying to get these people to try and drink lactulose. Give them an enema, it works just as well. Whereas the group that you've got the more lower grades, the grade 1s and the grade 2s, it's all about really trying to identify precipitating factor, infection, hyponatremia, whatever that might be, and really targeting that precipitating factor, but also thinking about those supportive measures as well, fluids and antibiotics. And the reason why giving fluid is so important is based on this study. It's a 17-year-old study, but it was a beautiful study because what they did is they took stable cirrhotics and they gave them a litre of normal saline intravenously, and they looked at what happened to their ammonia levels. And just giving them a litre of saline just over an hour, hopefully you can see that their plasma ammonia levels plummet, their urinary sodium excretion increases, their urinary ammonia excretion increases, and they get rid of their ammonia and they wake up very, very quickly. So if there's one thing that you do when you see someone who's acutely encephalopathic in the A&E or on the ward, is you give them a litre of fluid, and it works a treat. But what about more specific therapies? Well, what I've tried to do is I've put here, or tried to summarise where we are in terms of quite the limited number of therapies that we have for encephalopathy, but kind of tried to introduce it into my inter-organ ammonia kind of hypothesis. And really, you've got therapies that work on the liver, and that's basically encouraging or enhancing ammonia uptake by the liver into urea. And really the two that we've got there are LOLA and branched chain amino acids. You've got the gut, which is primarily the organ that we have targeted over the years, and I think we will increasingly do. And of course, I'm thinking about lactulose and rifaximin particularly, but I'm also going to mention microbiota transplantation at the end, which is really an up and coming area in terms of therapy. Or you've got something that's going to support the kidneys, and really I'm talking about giving fluids, or in a worst case scenario, if you've got somebody whose kidneys are failing, putting them on a hemofilter or dialysis. But really the biggest growing area is looking at the gut microbiome and its role in encephalopathy. And there's been a number of publications come out recently looking at the importance of the gut microbiome in many areas, but liver disease has been a particular area of growth, and I hope to explain to you in a moment why that might be important. And one of the reasons is that patients with cirrhosis get this concept of gut dysbiosis. So what that means is that they lose the beneficial bacteria in their gut, so the good bugs like lactobacilli and so on, and then they get these opportunistic bacteria taking over, which tend to be more ammoniogenic, so they're more likely to produce ammonia, and they're more likely to produce other toxic species. And patients with cirrhosis end up with having less diversity in their guts because they have sort of 2 or 3 big groups of bad bugs rather than a multitude of good bacteria that help to enhance immunity and homeostasis. And certainly we can show that, and this is a study of mine that we undertook at King's, where we looked at healthy individuals and we looked at cirrhotic individuals, and we looked at their stool microbial diversity. And hopefully what you can see is that the higher up here, the more diverse your microbiome is, and in health it's right up here. If you're a vegan or a vegetarian, it's probably more likely to be up here. If you're somebody who likes to go to McDonald's and Kentucky Fried Chicken, you're more likely to be down here. But your cirrhotics are here. They have reduced and less diverse microbiome, and the makeup of the bacteria that they do have is very much changed. And particularly they get a reduction in actinobacteria and firmicutes, which are 2 species that are very, very good for maintaining gut health and actually promoting integrity of the gut barrier. And of course, we use therapies in encephalopathy that primarily work either on the gut or the gut microbiome. And of course, lactulose is the thing that is everybody's go-to for any patient that will have encephalopathy. And why does lactulose work? Well, it passes unmetabolized through the gut into the colon, and it's actually the gut bacteria that break lactulose down into lactic acid and acetic acid, and they actually promote an acidic environment. But also lactate and acetate can also be used as an energy source by your microbiome, so they actually use it as food. But it's that acidic environment, that drop in the pH, which actually encourages free ammonia that's floating around and diffusing in and out of your gut and bloodstream to be converted to the ammonium ion, which actually stays in the stool, stays in the gut, and cannot then actively cross back across the gut barrier. So therefore, it encourages ammonia loss, as well as, of course, reducing the time that anything will stay in the colon. And we know that when patients present with overt hepatic encephalopathy, that when you send them home after an overt episode, that it's pretty much going to reduce the incidence of a recurrence of encephalopathy by about 50%. So if you look at an 18-month follow-up, a placebo group will probably have a 50% recurrence, whereas the lactulose group will probably have more like a 20% recurrence. So we should be sending our patients home from hospital who have inverted encephalopathy on lactulose, because it does prevent it happening again. But of course, we've also now got rifaximin, and our use of rifaximin really came about following the BAS study, which was published in the New England Journal a decade ago now, I can't believe. And that study looked at using rifaximin as an adjunct to lactulose. It wasn't instead of lactulose, it was with lactulose, and about 90% of the patients in both the groups were already on lactulose. And what that trial was able to do was to show that patients that had previously presented with encephalopathy, you could prevent the recurrence by, again, almost 50%, with an absolute risk reduction of about 25%. And really that has sort of come into people's armamentariums in those people where lactulose isn't really working, and then you would add it in as an adjunct to try to prevent them representing. And we've actually done some work to try to work out why rifaximin may be so helpful in this group of patients. And one of the things that rifaximin does is it reduces systemic inflammation, something that I showed you earlier is often driven by this bacterial translocation. And in this study where we treated people with placebo versus rifaximin over 90 days, you can see that there's a reduction in the TNF-alpha level in the bloodstream in those patients treated with rifaximin. So it's reducing systemic inflammation. And also, interestingly, it also reduces toll-like receptor 4 expression on white blood cells, particularly neutrophils, suggesting that there is less endotoxin being translocated across the gut walls in these patients. I'm lastly going to talk a little bit now about fecal microbiota, because this is a really big and growing area, and I'm sure many of you will have seen some of these papers published by Jas Bajaj looking at, and these are very early pilot studies, phase 1 studies, looking at the role potentially of actually changing the gut microbiome in patients with cirrhosis to improve outcomes. And he was particularly interested in looking at encephalopathy. Really what he's been able to do is show that giving FMT via an enema is both safe and potentially efficacious. And although in his first published study, he only had 10 patients in the standard of care group and 10 patients in the FMT group, he was able to show benefits in terms of increasing gut diversity and also reducing hospitalizations in this top panel, suggesting that there may be something in it. But of course, it's very difficult to administer enemas or indeed to give frozen stool into the gut via endoscopy. And therefore, he's also looked at using this in a capsular form, again in a phase 1 study, where he's given patients 15 capsules at presentation and followed them through to see if actually what happened, if their microbiome improves. And what he's been able to show is, again, that it's safe, and potentially that it may have some impact on clinical outcomes in terms of development of encephalopathy. I'm not sure if you can see this very clearly from this slide. So total encephalopathy presentations were down just in 10 patients. So there's certainly something there. And we've just recently finished a study at King's, the PROPHET trial, which was funded by the NHR, where we looked at the impact of FMT, but actually more widely in cirrhosis as a whole, rather than just people with encephalopathy. But what we did is, rather than use an enema, we actually gave liquid stool, which looks just literally like this, from healthy donors via a nasojejunal tube into the jejunum, so into the small bowel, where we know that gut dysbiosis is greatest. And this is very carefully screened. These people are screened to the same level that a blood donor or an organ donor would be assessed. And in the patients that we treated here, we didn't give antibiotics or rifaximin to, because we know that potentially would kill all those good bacteria, and then we followed them up. And what we were able to see particularly was that that the FMT in our trial actually normalizes, almost normalizes blood ammonia. So at 30 days, you can see that there's quite a profound reduction in those treated with FMT in their ammonia levels compared to placebo. But also, we're able to change the bacterial makeup of the gut as well. So, you know, a really bad bug for people with cirrhosis is Enterococcus faecalis. It's been linked also to people with bacterial peritonitis and to particularly poor outcomes. And patients with cirrhosis have this, but when you give them FMT, you can pretty much eradicate that bacteria from their guts. And also enteropathic E. coli, another terrible pathogen that we see that's also is associated with a high prevalence of bacterial peritonitis as well. So potentially we can really transform the outcomes of these patients. And what we're now going to do is the NHR have just funded an EME trial that we're going to now look at this in a multi-centre study across the UK. So I'm sort of coming to the end of my talk now, but what are my top tips? If I have 3 top tips for you, what would they be in terms of reducing and improving encephalopathy? So avoiding hyponatremia is very important. And you know, if people are very hyponatremic, for goodness sake, stop their diuretics. Don't keep people going with a sodium of 120. You've got to promote and build muscle mass, because this is so important, particularly in the metabolism of ammonia. And giving a bedtime snack, and I haven't really sort of gone into depth into all these sorts of references and studies, but this helps to prevent the breakdown of muscle overnight and keep people blood sugars a lot more stable overnight. And actually, when you give a bedtime snack, you actually reduce their rise in ammonia overnight. And hopefully, you know, these tips, amongst some of the other things I've talked about, will try to prevent this kind of revolving door of our patients that just keep coming in and out with encephalopathy. So my final slide, my summary slide, really is just to sort of summarise some of the important things that I've mentioned today. So early identification and diagnosis of encephalopathy. All have a go at doing the animal naming test if this isn't something you normally do. Think about referring for transplant those people who are presenting with overt encephalopathy, because you can really change these people's lives, and they have fantastic outcomes. Identifying correct precipitating factors. So we've talked about sodium, we've talked about avoidance of infection, nutrition, promoting muscle mass. I didn't really focus on the studies in this in view of time, but proton pump inhibitors exacerbate gut dysbiosis. So if your cirrhotic patients don't need to be on PPIs, please stop them. And a Mediterranean diet, so that's a diet that's particularly rich in fermented milk products and yogurts and things like that. That promotes a lot of lactobacilli in the gut, and which are very low ammonia producers. And this is also very important. So if people ask, what diet should I be on? A Mediterranean diet, because it's high in fibre, but also in fermented milk products. Secondary prevention with lactulose and rifaximin. And as I say, it's about intervening early and trying to prevent admissions if you can. So I'm going to stop there, and I'd be happy to take any questions if you have them.
Well, thank you so much. That was a masterclass, I thought, on hepatic encephalopathy. And I wonder if I could actually just kick off. I've got two questions, and then I think there are some on the chat. The first is in relation to the prognosis associated with onset of hepatic encephalopathy. I mean, as you know, we sometimes see patients who have chronic hepatic encephalopathy whose UCALD is, for example, 47, 48, and therefore do not meet listing criteria. To list them, I looked this up actually while you were talking, they would still need 2 admissions with hepatic encephalopathy. But of course, with rifaximin and so on, we can keep them out of hospital. I mean, do we need to change that, given the quite striking first slide that, 80% death at 5 years?
I'd argue that you do, and I think rifaximin was a game changer in many ways, because before rifaximin came along, people would be coming in 6, 7, 8 times, and it was a no-brainer. People would go through a transplant assessment process and be listed, and that's of course if they made it that far. And I think because rifaximin's come along, it is very good at preventing hospitalization, but it's not a fix for all people, and there are a number of people who rifaximin just won't work for. And I think also its efficacy probably wanes as the months and years go by. We know that people's gut microbiomes can overcome antibiotics very, very efficiently, I do just wonder if we should rethink our approach here, because even when they do get listed, of course, these are the people that will wait the longest, because as you say, their UCALD scores are so much lower.
Yeah, super, thank you. And if I can just sneak one other question in actually, please, before we go to the chat. I mean, is hepatic encephalopathy simply a harbinger of liver-related death, just a sign, or does it actually have a direct contribution, meaning that if we treat the hepatic encephalopathy well, we can actually improve their prognostic outcome?
That's a fantastic question, and I'm not sure there's a simple answer. It is definitely a harbinger of doom, I believe, and I think it's because the people that develop encephalopathy are probably those that have the worst gut microbiomes and the leakiest guts, and therefore they have got a huge amount of bacterial translocation going across and a lot of systemic inflammation. And of course, we know systemic inflammation is a driver not just for encephalopathy but for variceal bleeding. I've already mentioned that bacterial translocation will drive bacterial peritonitis, and then of course you've got the hepatorenal syndrome that will then develop. So I think it is a very, very important factor, and when people are starting to develop ovarian encephalopathy, I think you have to be saying this means they're not going to do very well, and we need to be thinking about it.
Super. Right, 2 questions from the chat room. First is from Barbara Herald in Sheffield, which is how do we distinguish hepatic encephalopathy from alcohol-related brain injury, but by the way, other brain injuries? And secondly, how do we get access to branched chain amino acids as part of the treatment algorithm?
Oh, 2 very good questions. I didn't, in the interest of time, I didn't have a slide on this, but in when you're looking at somebody who's potentially got encephalopathy, I think brain imaging is very, very important, and that can help to differentiate what's encephalopathy from what might actually be a more of a physical problem within the brain. So Barbara's absolutely right. Alcohol-related dementia. You've also got that cerebral atrophy that you get in anybody who spends their life drinking, and that certainly does have an effect. We also, I think it's quite commonly difficult to differentiate things like Alzheimer's from encephalopathy, but actually if you look at an MRI scan of a brain, you get hippocampal atrophy in somebody with dementia that you don't get with encephalopathy. So I think I would encourage people to do some brain imaging. Of course, classically, people with encephalopathy often get a CT scan because often they've had a fall and people are looking for bleeds, but actually ask your radiologist, is there hippocampal atrophy? Because that can be an indicator that there might be dementia there, which you just don't see with encephalopathy. In terms of branched chain amino acids, in Scandinavia, this is probably their favourite treatment for people with encephalopathy. So everybody gets branched chain amino acids. The trouble is that we don't have huge, robust trials, randomized control trials showing their role in liver disease that would encourage it to be more widely used, I think, in the UK. They are available, and you can ask your pharmacist to get hold of branched chain amino acids. So there's one brand called Bromino, but there's many others. And you can ask your pharmacist to get hold of branched chain amino acids. At the end of the day, they're just amino acids. They're probably another reason why people with liver disease do so much better who are NG fed when they're sick, because your NG feeds are also full of branched chain amino acids as well. So speak to your pharmacist. You can get hold of them.
Super. Now we're running a little bit behind time, so and you've just had a flood of questions come in, so I'm going to choose.
Sorry.
And then we'll draw to a close. The first is there any evidence for using a probiotic such as VSL3 in hepatic encephalopathy? And that's from Grace Dolman. And the second question is, what is the contribution of sarcopenia to the development of hepatic encephalopathy, which is from Tess Cacciatola.
So sarcopenia, obviously I showed you that slide with the mid-arm muscle circumference, and basically there's a pretty direct correlation between the less muscle that you have, the more likely you are to have encephalopathy. So sarcopenia is very, very important, and many sarcopenic patients are encephalopathic. So that's kind of my answer to that part of the question. Remind me, what was the other part of Grace's question?
The role of probiotics such as
probiotics, of course, yeah. So again, I didn't have time to show you all this, but Jas Bajaj has done a nice study with probiotics. He looked at Lactobacilli GG in a small randomized control trial. And actually, it did have some quite profound effects. It does reduce gut dysbiosis. It reduces bacterial translocation. But I think we need bigger studies. There's nothing out there that would kind of be a game changer in terms of changing practice. But certainly, if your patients want to take probiotics, they will do no harm.
Superb. Well, I'm going to close it there. Thank you very, very much. That was a really superb talk.
My pleasure.
I hope we'll hear from you again soon.
Thank you. Thank you, everyone.
Thanks. Bye-bye.
Bye.